Well, I'm Dr. Cristina Echeverría from Buenos Aires, Argentina. I'm very happy to be here. I'm working with the IPC from many years. So the idea today is to talk about treatment options for high impact areas. These are my disclosures, and I will cover 4 key aspects for managing patients with this psoriasis in these high impact areas. This table highlights the high impact areas in psoriasis, but I will focus on the first two, scalp and face and genital, as the others have already been covered by Tiago. Let's begin with the scalp psoriasis. It affects between 45 to 56% of patients, and the primary symptoms include itching and pain with a high psychosocial impact regardless of the affected area. The presence of hair makes topical therapy treatment difficult to issue like absorption and unwanted cosmetic effect. This complex treatment often becomes a barrier to adherence. Additional inflammation of the scalp can affect the quality of hair, sometimes leading to alopecia. And you have to remember that a characteristic sign of scalp psoriasis is the presence of lesion along the hairline, which can be a key diagnostic feature. I would like to show you here a treatment algorithm divided based on the severity of scalp psoriasis and whether there is significant whole body involvement or not. On the left side, for patients with mild to moderate localized psoriasis, scalp psoriasis, that means less than 50% of the scalp affected, and minimal involvement of the rest of the body, the recommended treatment includes topical therapies such as corticosteroid, vitamin D analogs, keratolytics, and coaltar preparation. And if there is no improvement, target phototherapy like UVB or examen laser or also intralesional corticosteroid may be considered. On the right side, for patients with severe scalp psoriasis, that means more than 50% of the scalp affected, but without significant body involvement, the author proposed a similar approach that for mild to moderate cases, recommending primary topical therapy and scalp phototherapy devices. Interestingly, the algorithm does not suggest major difference in treatment between mild to severe forms of scalp involvement, where there is not extensive body involvement, which really is noteworthy because we know that patients with a very high impact in scalp psoriasis with a very big involvement, I think they need more aggressive therapy. Finally, for patients with moderate to severe whole body psoriasis, along with scalp involvement, whether it is mild or severe, systemic treatment are recommended, and these include traditional systemic agents and biologics and small molecules. This treatment can be combined with topical therapies when necessary. One important thing to take into account is the burden of using topical therapies, and we can see here, according to this survey, patients with involvement of one or more special areas report a significant burden, with more than 85% rating the use of topical treatment as moderate or very burdensome. And this is especially notable for patients with scalp involvement. I will talk you a little from about topical therapies, and among them we can see here a real-world data from a prospective observational study evaluating the combination of calcipotriol and betamethasone aerosol foam for scalp psoriasis. And over 4 weeks, a significant shift occurred in patients classified as mild that increased from 12.4% to 85.5%. The combination provides the benefits of both molecules with minimizing the side effects typical seen when these drugs are used individually. And this results in a significant decrease in symptoms like itching, erythema, flaking with better tolerability. As you know, unfortunately, we don't have head-to-head comparison of all systemic drugs available for the treatment of this patient. So I will now show you a systematic review evaluating the effectiveness of biologics and apremilast treatments for randomized for scalp psoriasis, and it analyzed data from randomized controlled trials to compare early, late response, and long-term treatment outcomes. The results show for early response, both infliximab and secukinumab deliver excellent rapid results. For late responses, there is no difference in efficacy among various biologics, and in terms of drug survival, ustekinumab has shown the highest sustained efficacy over time. In relation to the effectiveness of small molecules, these slides demonstrate that the brevactinib is significantly more effective than apremilast by week 44, and it's remarkable that the difference is already significant at week 16. Here we can see that the response to the brevactinib continues to improve over time, reaching an scalp-specific psoriasis PGA rate of almost 70% at week 52 in patients receiving continuous treatment, and a similar response in those who switch from placebo. And as you know, maybe at the recent ADB Congress, data up to 4 years was presented, showing that clinical efficacy was maintained in patients receiving continuous brevactinib. Now I will show you real-world data on ixekizumab for scalp psoriasis, and in this 52-week study with 99 patients, 96% achieved a scalp PGA 0 to 1 by week 52, with rapid response seen early on as specific PGAs dropped significantly by week 16. Now let's look at risankizumab, and in a similar real-world setting in this 52-week retrospective study, almost all patients achieved scalp PGA 0 to 1. The response was rapid, with near 87% reaching this outcome by week 16, and it remained consistent through week 52. Finally, I like to discuss this single-center retrospective study involving 308 patients with scalp psoriasis, and it compares the effectiveness of anti-IL-17 and anti-IL-23 in difficult-to-treat areas. And the results for scalp psoriasis showed that IL-17 inhibitors demonstrated superiority over IL-23 inhibitors, with 86% of patients achieving a psoriasis scalp severity index 100 at week 52 compared to 71% for anti-IL-23. Now let's move on to genital psoriasis. As you know, this condition is characterized by itching and pain with symmetrical red plaques that often lack scales due to moisture and maceration. It frequently affects the glands and vulva and is often misdiagnosed as a fungal infection, leading to delayed treatment. These plaques can develop fissure and erosion and are prone to candida superinfection. Additionally, the condition has a significant impact on sexual health, affecting both physical and emotional well-being. I will show you this treatment algorithm derived from a review article, and the others highlights that these areas of the body have thin and sensitive skin, making them more vulnerable to side effects, so treatment must be carefully tailored. For patients without moderate to severe total body plaque psoriasis, the recommended treatment approach begins with topical corticosteroid. And I think that if weekly the condition is refractory, second-line options include topical calcineurin inhibitors or topical vitamin D analogs. Other alternatives for topical therapy are coaltar preparation or topical PDE4 inhibitors like crisaborole. Additionally, you know that roflumilast, another PDE4 inhibitor, is now available and serves as an effective treatment option. But I think we have to move very fast if we have a refractory disease to systemic agents. And the recommendation in this algorithm is that if you have patients with moderate to severe total body plaque psoriasis or those who are refractory to topical therapy, the first-line options are IL-17 inhibitors like ixekizumab. If the response is insufficient, other biologics and systemic therapies would be considered, and also apremilast. Let's talk about crisaborole. The slide presents the result from a double-blind randomized vehicle-controlled trials assessing crisaborole 2% ointment applied twice daily for the treatment of intertriginous, anogenital, and facial psoriasis. And we can see that after 4 and 8 weeks, the crisaborole group shows a significant improvement compared to the vehicle group. And additionally, there are warning reported side effects. Let's talk about roflumilast, and in the DERMS 1 and DERMS 2 study showed that after 8 weeks, patients on roflumilast cream achieved significantly higher clearance rate measured by the intertriginous investigator global assessment for this area. Present data from Ixoracu that you know it was the first phase 3 randomized double-blind placebo-controlled trials that was specifically designed to evaluate therapy for genital psoriasis. And this study highlights the rapid onset of action with significant difference in response early observed by week 1. And by week 12, 73% of patients treated with exekizumab reached an SPGA-G of clear or almost clear that was sustained by week 52. Let's talk about new data from guselkumab. The Gulliver study is an observational prospective real-world study aimed at assessing the effectiveness and safety of guselkumab in adult patients with facial or genital psoriasis. And the data shows by week 12, 83% of patients with facial psoriasis and 76.5% of patients with genital psoriasis have achieved an SPGA score of 0 to 1 and experience a 2-grade improvement in severity. And this improvement continued to increase through week 28. And we can also observe improvement in the individual components of psoriasis. This slide presents data from a real-world retrospective study evaluating the effectiveness of risankizumab in patients with genital psoriasis over 52 weeks. And again, the result shows a good result with almost 85% of patients achieving SPGA 0 to 1 by week 16, and all of them by week 52. And what about the data we have about bimekizumab? Well, here we have data on this effectiveness of genital psoriasis in a real-world setting, and by week 16, more than 98% of patients achieve an SPGA 0, that is completely clear genital skin. Notable, even by week 4, 3 out of 4 patients had already reached almost clear skin, which highlights the rapid action of this drug. Continuing with the real-world data on effectiveness of biologic for genital psoriasis, this slide presents a single-center retrospective analysis of 136 patients, and they compare the efficacy between IL-17 and IL-23 inhibitors. Well, the study shows that there was a similar efficacy between both classes of biologics, and you can see in the graph, by week 52, 98% of patients treated with anti-IL-17 and 92% of patients treated with IL-23 inhibitors achieved a PGA G 0 to 1. In relation to the use of small molecules, the slide presents data from the discrete trial that it evaluates the use of apremilast in patients with moderate to severe genital psoriasis, and by week 16, a double of the patients on apremilast achieved a PGA G 0 to 1 compared to placebo. For pruritus involvement, 47% of patients in the apremilast patients saw at least 4-point decrease compared to almost 20% on placebo. As we can see here, there are 2 ongoing clinical trials focusing on patients with psoriasis in difficult-to-treat areas. These studies involve molecules such as the upadacitinib, tildrakizumab, risankizumab, and the novel oral IL-23 receptor antagonist peptide, highlighting the increasing focus on developing effective treatment specifically for patients with genital psoriasis. To conclude, psoriasis in special areas carries a high disease burden. This often leads not only to physical discomfort, but also significant psychosocial impacts, including depression, isolation, and challenges with sexual health and daily activities. Fortunately, both topical and systemic treatment, whether using alone or in combination, have been shown to be effective and safe for managing psoriasis in these sensitive areas. Lastly, the importance of early diagnosis and quickly starting the right treatment cannot be overlooked. Tailoring the therapy to the individual needs of each patient is crucial to reducing the psychosocial impact and improving their overall well-being. Thank you very much.